Hello friends, welcome back to our new session. In this session, we will discuss about the remaining part of surgical nutrition. Surgical nutrition. In last recording, we have discussed about the enteral nutrition. Now in this particular session, we are going to discuss about the parenteral nutrition. Now we'll talk about parenteral nutrition. Okay, the enteral nutrition is that nutrition that is given through the enteral route, through the stomach or through the intestinal route is called as enteral nutrition. But in this session, we will discuss about the parenteral nutrition. In parenteral nutrition, first is indication. First is indication. Indication of parenteral nutrition. Okay. The first indication of parenteral nutrition is prolonged paralytic ileus. Prolonged paralytic ileus. If it is more than 72 hours, then it is called as prolonged paralytic ileus. Second is high output fistula. High output fistula. If we have done any kind of GI surgery and the enterocutaneous fistula is found, it is of two types. First is high output fistula and second is low output fistula. High output fistula is more than 500 ml or cc in 24 hours. Okay. If it is less than 500, then it is called as low output fistula. Third is initial phase of initial phase of acute severe pancreatitis. Acute severe pancreatitis. Fourth is acute episode of IBD. Acute episode of IBD. And fifth is short bowel syndrome. Okay, short bowel syndrome. These are the 5 indication of parenteral nutrition. Okay, in short bowel syndrome, mainly the length of small intestine is less than 200 centimeter. Then in this situation, we have to use the parenteral nutrition for long time. Okay, now we will discuss about routes of parenteral nutrition. Now we will discuss about routes of parenteral nutrition. Okay. In this particular section, we will discuss about 3 routes of parenteral nutrition. First is peripheral, IV line. Second is PIC line, and third is central line. Okay. These 3 routes are there for routes of parenteral nutrition: peripheral IV line and PIC line and central line. These 3 routes are there for parenteral nutrition. Okay. In peripheral line, okay, the peripheral line is least preferred method. Least preferred method. Okay. Why it is least preferred method? Because if we will use peripheral line and the sugar rich solution we are using in parenteral nutrition, in that case, the high chances of thrombophlebitis. Okay. Due to this, there are high chances of least preferred hota hai. Second is, it is if we are using sugar rich solution, then chances of thrombophlebitis is increased. Chances of thrombophlebitis is increased. Okay. In PICC line, the full form is peripherally peri peripherally inserted central catheter. Okay. And third is central line. The roots are subclavian, internal jugular vein, and femoral vein. Femoral vein. In this, subclavian is most commonly used, but most safe is IJV. Okay. In next term, we will use we will discuss about the central line. Okay. In central line, different vessels are used. Different vessels are used. Okay. Just like subclavian vessel, IJV, and femoral. These three vessels most commonly are used. Okay. In these three vessels, risk of infection is least in subclavian. Risk of infection is least in subclavian and maximum in femoral. The question can be asked like that: in which route of central line insertion maximum chances of risk of infection is present? Answer is femoral. The risk of thrombosis, thrombosis. If infection chances is least, then risk of thrombosis is also least. Okay. When the chances of infection increases, then risk of thrombosis is also increases. Okay. This is also maximum. And risk of pneumothorax is maximum in subclavian and least in femoral, or least you can say no risk of जो है वो pneumothorax is present in femoral. Okay. In this type, just like this is clavicle, this subclavian vein is going, so this way we are using this way we are using the central venous catheter for insertion. Okay. So when we insert this, okay, there is apex of lung. So sometime during insertion, this apex of lung is hit by our thick needle of central line insertion. So the risk of pneumothorax is maximum in subclavian type of uh, central line insertion. Okay. Next, we will discuss about best vessel for TPN insertion is subclavian vein is the best method of TPN insertion. Okay. Next, central line. Okay. Most commonly used and safe method is IJV. And internal jugular vein is most commonly used method. Okay. It is inserted with the help of USG. Nowadays, USG guided insertion is done so that eventful process can be prevented. After central line insertion, always after central line insertion, always do chest X-ray. Okay, always do chest X-ray. Why? To to document position of tube, to document position of line, and second to rule out pneumothorax. Pneumothorax. To rule out pneumothorax, we have to do this chest X-ray all the time. Okay. Now we will discuss about the next point is composition of parental nutrition. Composition of parental nutrition. Okay. Total parental nutrition is usually 1 liter to 2 liters. Some companies make 1 liter pack and some companies make 2 liter pack. It always provide 2000 kilocalorie per day. Okay. In this peripheral nutrition, TPN, protein, fat, and carb ratio should be 20 ratio 30 ratio 50. This is a very important concept. In this segment, protein, fat, and carb ratio should be 20, 30, and 50%. In US, carbs use as a 60 to 70%, amino acid use as a 10 to 20%, and fat use as a 10 to 30% of TPN solution. Okay. Next, depending upon concentration of carbohydrate, TPN solution is of two types. First is high osmolarity solution, and second is low osmolarity solution. There are two types of solution are present. First is high osmolarity and second is low osmolarity. In high osmolarity solution, high concentration of carbohydrate is used. High concentration of carbs is used. Okay. If concentration of carbs is high, CO2 evolution will be increased and respiratory quiescent ratio will be always more than 1. Always it will be more than 1. Okay. But in low osmolarity, always RQ is less than 1. Okay. Because low CO2 is excreted. So in high osmolarity and low osmolarity, what is the difference? RQ is more than 1 and RQ is less than 1. Okay. In next concept, where if concentration of I have already told you, if concentration of carbohydrates is high, there is always high chance of thrombophlebitis. Always high chance of thrombophlebitis. Always. And this low osmolarity solution, they are all preferred in pulmonary failure patient. pulmonary failure patient. Why it is used in pulmonary failure patient? Look, this is the concept. Okay, because in pulmonary failure, lungs are already not working properly. In that situation, if you will produce high carbohydrate and lungs are not working properly, then this CO2 will retain in the body and it will cause respiratory acidosis. But if you will use this low osmolarity solution, then low CO2 will be produced. In that situation, lungs that are not working efficiently can also remove this CO2 and no metabolic change will occur. So it is used in pulmonary failure patient. Okay. Next, we will discuss about renal failure patient. Okay. In renal failure patient, if kidneys are not working properly, fluid restriction is the treatment. Fluid restriction is necessary. Is necessary. Fluid restriction is necessary. In that situation, low quantity of low quantity of fluid TPN is required. Low protein is required. Low protein is required and high carbohydrate is required. High carbohydrate is required because if you will give high protein, okay, it will cause nitrogen imbalance, and if you give high amount of fluid, then high amount of fluid will cause more kidney failure. So in renal failure patient, these three things should be considered. In next point, we will discuss about complication of parenteral nutrition. Complication of parenteral nutrition. This complication is of two types. First is central line related complication. Okay. And second is feeding related complication. Feeding related complication. Central line related complication and second is feeding related complication. Okay. In central line related complication, first and most common complication is pneumothorax. Pneumothorax. Okay. Second is air embolism. Third is thrombosis. Thrombosis. Fourth is migration. Fifth is blockage. Blockage. Okay. Fifth is blockage. Fifth is blockage. In all those situations, what we need to do, catheter related complication, what we need to do, remove tip of line and send for culture if we are suspecting infection. Okay, this is central line related complication. In feeding related complication, weight gain starts in 5 to 7 days, but earliest excessive weight gain earliest excessive weight gain is seen, then it is a sign of volume overload. If you weigh the patient daily, if you weigh the patient daily and daily 1 kg weight increasing, then it is a sign of volume overload. Okay, we have to weigh the patient daily, and if daily 1 kg weight is increasing, it is volume overload. Other complications are, most common is hyperglycemia. Hyperglycemia. It is due to overfeeding. Okay. Fourth is cholestasis. Cholestasis. In this change, LFT, liver function, is deranged. Deranged. In that case, we have to sometimes stop feeding, or fat-free solution should be used. Fat-free solution should be used. Fifth is zinc deficiency, and sixth is hypo or hyper, either glycemia, calcemia, and sixth, seventh is re-feeding syndrome. These are the complication of re-feeding syndrome.